Hello, this is Dr. Centeno and Dr. Schultz. And as you know, I get on once a week. I try to answer patient questions. Usually we either have a guest like we do today, or I've got some didactic stuff to talk about, and then we'll talk about that or anything else. In this case, we've got John Schultz. John has been my partner now for over 20 years. And because of that, he was there really from the very first cases of the PICL procedure we did way back in 2015. John is an anesthesiologist by training, and also like myself, my background is physical medicine rehab, and we both came into interventional spine, and both actually knew the same people in our community. So I met John, I don't know, John, what do you think? I think you and I met maybe 15 years ago. No, I'm sorry, 25 years ago.
25.
Yeah, like 25 years ago at a surgery center.
Yep.
And then eventually teamed up and partnered. So welcome.
Thank you very much. It's great to be here, Chris.
Yeah, so I thought we would go into just some basic things about CCI, PICL. Like I said, John's been with me there from the very beginning. So one of the things that patients may not know is that John did all of the early anesthesia for PICL. So John, let's get into that. If you recall, way back when in 2015, you know, the anesthesia for PICL is complex. So I don't think I let any other anesthesia provider touch a PICL patient for the first 100 cases. So what do you remember around that time period?
So 2 landmark changes. So we did the first PICL probably late at night at a surgery center. First flight, just like the Wright brothers, right? So it had never been done before. All of a sudden, we're poised there. I know the airway, you know the anatomy, and through faith and a lot of perseverance, we took off and it worked. And with that, every single procedure subsequent has been improved. It's the little nuances. So we first started, believe it or not, with a tongue depressor, trying to find our way in the back of the oral pharynx to put a needle next to the spinal cord, which also is where the alar ligament is. So it started at a very basic level. And since then, Chris, through watching you and your mastery, it's only improved.
Yeah, and let's talk about that whole thing and go down that thread a little bit, you know, that process of continuous quality improvement.
Sure.
You know, I'm a big believer in that. And I think most patients believe that procedures and doctors doing procedures are magic. And what I mean by that is that I think most patients don't understand that when it comes to either developing a new procedure or trying to learn an existing procedure, that doctors aren't human, right? And what I mean by that is that repetition for all humans matters in how good you are at something. And so we have doctors that are really good at upper cervical fusion because they do it all day, every day. We've got doctors who are probably not so great at upper cervical fusion because they do it maybe 10 times a year. So go into that concept of repetition, starting a new procedure. What are your insights into all of that to try to get patients to understand that doctors are human beings and they learn new things or get good at new things or not?
Sure. So the traditional medical paradigm is see one, do one, right? That's with the Ivy League.
So tell them what you mean by that. So that is a great talking point. You know, in medicine, there's this saying, see one, do one, teach one. So what does that mean?
What that means is you come in and observe, you have an attending, a fellow teach you, then you get the basics, then over supervision, you may get to do one, and then you're on your own. But I think it's really important, and you know this, is there was no roadmap. This was a brand new procedure never done before in the history of medicine. So there we are. You know the anatomy, we know the airway, and it was through a lot of grace and expertise that it got performed. But with that, every single case, we thought about enhancements, how to get it better, how to improve. Because at the end of the day, it's about the patient. It's about their outcomes. So this is much different than the paradigm that most medical institutions use.
So everyone, if you're just joining us, this is an interview with Dr. Schultz. Dr. Schultz has been there from the very first PICL procedures with me. If you're interested in asking a question, then just type your question in the comments. If you're on Facebook or on YouTube, we'll then see your question here and we can field that question. As usual, we'll spend probably 15, 20 minutes talking, and then we'll go to answering some questions. So diving a little deeper there, John, let's talk about the PICL procedure from an airway perspective. What makes it unique and different than other procedures that might involve interventional spine, for example?
Sure. So that's one of the largest challenges. Even after 10 years of doing it, it's still a challenge, and it's the nuances. We are working in the airway, right? We are working in the airway, and most ENTs work in this space. Other oral surgeons work in this space, but they have a breathing tube in place so they can safely manage the airway. Not true with the PICL. So it's the nuanced dance of knowing the airway, knowing the sedation level that you need to be able to safely put a needle in the back of the throat. So it takes a high degree of expertise and familiarity with the airway. For example, as you remember, Chris, our first case was with a tongue depressor, right? We put a tongue depressor in there and we were looking in the back of the anatomy, but then that gave way to the airways that the GI doctors used. And that wasn't sufficient for us. So then we went to a 3D printed model. And that wasn't enough.
So let's talk about that. So the first thing we used was a little piece of plastic made for GI cases. Now, what's interesting is that there's a reason, right, why you can't have a breathing tube in. There's a reason why you can't use metal ENT devices. So talk a little bit about that. Why wouldn't we use a breathing tube? Why wouldn't we use just the metal devices that ENT doctors use?
Yeah, so a breathing tube would obscure or prevent us from seeing where we need to put the needle. So that's a no-go right from the beginning. So we need to be able to see that. And we also need for the patient to breathe and be sedated. So it's quite a challenge, and that's what underscored in part each evolution of the airway. First with that hard plastic one, and then we went, if you remember, to the 3D modeled one where we had a lab print from a 3D model different airways.
Yeah, so these little airway devices. Now, what's interesting is, I think, John, you were the one that, so our first 3D printed one, we had one of the guys that was working with us at the time design it with some feedback from us. But I think you were the one, John, that recognized that, I think you maybe had a friend that was a dentist or something and said, well, those guys use bite blocks. Can we start to use bite blocks in this whole thing? So describe that. What changed from that first model to the second model, and how were bite blocks involved in that?
Sure. So we knew we had to have improved airway management and observation of the back of the throat. So if you've ever had a dental procedure, you know that they put in a block and then they put in a rubber dam. So it's that little kind of triangular wedge that most patients have in a dental setting if they have extensive work done. I utilize that as a base. So you put it in the back of the back of the teeth to prevent them from biting down. And then we configured an apparatus to fit in that to then further depress the tongue, which would allow us a much better view of the target in the back of the throat.
And now that's evolved quite a bit. We now have a fifth generation mouthpiece that I've been trialing this last month that has really, again, upped the game quite a bit. So getting more now, John, onto the topic of, you've been there since the first cases. Talk about your experience with PICL. How many cases have you done? Let's start there. You've been at this a long time.
I've had the pleasure and opportunity of watching you side by side for the first year. So we went there, we got improvement, and now I've probably done 500-600 cases, and it is a game changer. And what I mean by that is, you and I previously were treating knees and shoulders, and we still do. But for these patients with craniocervical instability, some of them are so severely impacted that they're bedbound, they can't go out. This is transformative. This is taking a person that had a normal life, and now they have the ability to get to go out to see their family. That's transformative. So in many ways, I find this to be sacred work. To give someone that opportunity to get their life back is huge.
Gotcha. And so kind of going down that same thread, in the patients that you've treated with PICL, what are some of your more amazing results? Obviously I know my own patients, but I don't tend to have insight into yours. So tell us about that.
Yeah. So I've been doing this for over 5 years. And when probably 4 years ago, I had the pleasure and the honor of treating 2 young women at the time, and they were from France. And they had hypermobility, so much that they had to stop their schooling because their knee would sublux or they would position down and they'd get the CCI. Well, I'm here to say that 4 or 5 years now have passed, and these young girls are now women. They're not only women, they are thriving. And they finished their high school and they went to university. So I've been able to watch them and their mothers take a completely different route as a result of the PICL.
Great. And let's talk about that development. For example, the big leap that was made, started maybe 1.75 years ago, from PICL to EPICL, and how that works in our clinic, right? If I'm doing something, obviously I'm right there, you're right there. So how do we communicate those advancements that we're making to each other, and to make sure that the other doctors in our clinic that are doing PICL understand all of that?
Sure. The physicians at the clinic, you and I and Dr. Pitts and Dr. Markle, are very special in that we are intimately interested in the nuances. And by what I mean by that is you'll come down and you'll share a case and you'll show the contrast pattern. Like, oh, look. And we genuinely get excited. And then there's chatter for the next week or so. How do we do this? What do we think? It's that communication I'm right across the hallway from you, and Pitts is right down the hallway. So when there's a new advancement, it's like wildfire in the clinic downstairs, because that's what we've dedicated our lives to. When you find an advancement, now we have a better potential of transforming lives. So communication is fluid. This is not the big university where we're a department away and we're not interested. We're right there. We're right by the bonfire of expertise and education.
So this is an interesting one here. I know this person, and this kind of a question gets to what we were just talking about. And to answer Julie's question here, about 2 years ago, there was a reassessment of how we did this PICL procedure. So just make sure everyone's on the same page here. PICL is a procedure where we come from the front. We directly access the ligaments that hold the head on. We inject bone marrow concentrate, which contains the patient's own stem cells, to try to get the ligaments to heal. And the goal is to avoid the need for an upper cervical fusion. Now, we did that a certain way for about 8 years, and that improved and improved and improved. But about 2 years ago, there was some additional information I came across in doing many of these procedures that really changed things. So we had recently, maybe a year or two prior to that, decided to go to dual axis x-rays. So we had x-ray coming one way, AP x-ray going the other way, lateral. And as we made that switch, I started to see that there was a better way to do the procedure, that the way that we'd always done it was good, but we could get to excellent, and we could drastically improve targeting. And that then became the E, or enhanced PICL procedure. So John, talk a little bit about, you've done it both ways on the x-ray front, right? With a single C-arm going AP lateral, AP lateral, AP lateral, and the dual axis x-ray that we currently use. Describe the difference and why we went to that second x-ray.
Sure. So just for all of the listeners, we advance and place the needle through the use of x-ray. So we take a picture, we advance the needle, we take another picture. So in our prior practice, or prior to EPICL, there was the need for taking it this way, and then we would change the beam to vertical AP. So we'd go AP lateral, which was necessary for the safety of the patient. However, that was time consuming, and also oftentimes the patient would move because it's a nuanced dance. What if the airway changes? What if the patient becomes a little bit lighter? And so it didn't allow for the level of excellence that the biplanar, both AP and lateral simultaneous, affords. And just to give everyone an idea, this biplanar, the AP and lateral simultaneously, does not exist anywhere else. And these machines are not inexpensive, and they're very large. So it's a cramped area, state of the art, that allows us live precision.
Yeah, and that's a good point, meaning nowhere else in interventional spine do you see dual axis x-rays being used. They use them a lot in cardiology.
Right.
They'll have two set up in interventional cardiology procedures. But when it comes to interventional spine, where Dr. Schultz and I are both trained, you just don't see two x-rays being used at once, primarily because they're expensive, right? A good x-ray unit costs as much as, the most expensive Tesla, $130,000, $140,000, $150,000. So, and then if you add on top of that the equipment we need, which is digital subtraction angiography, that then is a $20,000 kicker on top of that. And then all of that has to have an x-ray tech to run it. So that's $100,000 a year person, or let's say $70,000 to $100,000 a year person. And all of that needs to be situated in an x-ray isolated room, which adds additional cost. And that room has to be big enough to accommodate that machine. And then the concept of having two of those machines in a single room is just not financially feasible for most interventional spine guys. So it just doesn't exist outside of this procedure in interventional spine. And okay, well, let me see, John, if there's any specific questions for you. One of the reasons why I wanted to have Dr. Schultz on, and if you're watching this and you haven't given us a like, please do that now, because that's how other patients find this content, using the algorithm on either YouTube or on Facebook. And we really want to make sure that other patients like you can find this content. So if you want to pay it forward to other people in the CCI community, give us a like now. And also just give Dr. Schultz a thumbs up. But let me see if we've got specific questions here that I want to have you jump into. I think that's it. If anyone has any specific questions for Dr. Schultz before I let him go, that would be great. John, any parting comments that you
Sure.
have about this whole endeavor of PICL? And so let me open the floor to you.
Well, thank you. Again, thank you for this opportunity. Thank you for leading this charge. Again, this is sacred work. It's so important because it's transformative to both patients and families. I think what many patients and many families don't understand is the nuances of this procedure. We've been doing it for 10 years now, and every little thing is nuanced. So that's to say, the airway, the mouthpieces, the biplanar fluoroscopy, the placement of the needle, how to advance the needle in the upper cervical spine next to the spinal cord, the flow of contrast. That cannot be mimicked. That cannot be appreciated by an overnight 1 or 2 procedures. This is dedicated work that requires absolute concentration and devotion. So there may be other people out there trying to say they do this, but with us, it's 10 years of dedication.
Yeah, and actually, John, that brings up a good point. So we've had this bizarre situation in our clinic where we had 2 doctors show up. One, I think, was just there for some routine low-level training, who saw me do this procedure. Maybe he watched you do one, I don't recall. And the next thing you know, he's back to Europe trying to replicate this. Had a bunch of complications. I tried to shut it down, couldn't shut it down. We had to kick him off of the Regenix network because of that. Another person really showed up under false pretenses, wanting to, the stated reason this person was there, she was there because she wanted to see us do some procedures with knees, hips, shoulders, lumbar spines, etc. The next thing you know, she's hanging out only with me watching PICL. I think she observed 2 procedures. So let's talk about that. What is the likelihood that someone a couple of years ago could have watched 2 procedures and have any idea of what they're doing with this particular PICL or EPICL procedure?
It's 0. But more importantly, it places patients and their families at extreme risk. I mean, even start at the basics, the airway, the nuanced dance. You need to know how to manage an airway, and most physical medicine or surgeons don't know how to manage an airway. I've been blessed that I've trained. The airway, the 3D printed, we're at the 5th generation. X-ray, how many X-ray techs know even what a 0-1 joint is, let alone how to image it? How to place a needle. You and I have spent a lifetime nuancing small movements right next to the spinal cord. That takes 10, 20 years of work. And then how to read the flow pattern. So the chance of someone watching a procedure, 1 or 2, and thinking that they are competent, 0% chance of them successfully performing.
Yeah, I would agree with that. I think you could sort of fake and bake it, or try to fake and bake it but man, there's so many decisions that get made during this procedure that require so many nuanced decisions. Is your flow pattern correct for your position? Should you go more medial or lateral? Should you go superior? Should you go inferior? Are you in the tight bundle of the alar, the loose bundle of the alar? Are you in another?
Are you in the bursa?
Are you in the bursa? Are you in the accessory ligament? Are you actually in the transverse ligament or just in the bursa?
Right.
There's just a few dozen decision points that need to be learned in order to do this procedure correctly. And obviously, in any two procedures, you might see one or two or three of those, but you're not getting exposed to all of them. Well, thanks so much, Dr. Schultz, for being with me here today. I did want everyone to understand. John is doing a lot of PICL procedures these days, and I wanted people to understand who John is as a person and as a provider, so that they could have some idea of all of that. So thanks so much for spending your Sunday morning with us. I'm going to get to some questions here. Really appreciate you being here.
My pleasure, Chris. Thank you, everyone.
Thanks. Okay, guys, so we will get to some questions. Now we got lots of questions here built up. So do we perform stellate ganglion blocks? Yes, we do. Or would you accept one because I have MECFS and anxiety, stress, and sleep problems? I'm not from the USA. I think what you're asking is, can you get a stellate ganglion block elsewhere? You certainly can. You got to make sure they stay away from corticosteroids and stay away from bupivacaine, but you certainly can. I think that's the question there. What would the symptoms of instability, or what would symptoms of instability around the C4 disc be? We don't, a disc is named C4-5 or C3-4, as is a spinal level. So there's no such thing as a C4 disc. It'd be a C4-5 disc or C3-4 disc. When it comes to the 3-4 level, the 3-4 level can provide some upper cervical type symptoms. So that's one we always look for to try to see, are we dealing with upper cervical spine, which is 0 through 3, or are we dealing with a 3-4 problem? Because that can be and look like upper cervical. So for instance, there's been reports of headaches and dizziness that can come from the 3-4 level, even though it's much more common for that to come from 1-2 or 2-3. Amen. How much percentage is used in prolotherapy to treat the upper cervical spine? Yeah, so when it comes to prolotherapy percentages, normally it's 10 to 15% dextrose is what is used. If it's 5% dextrose, then that's actually more a type of prolotherapy solution that's used around nerves for higher dissection. But as far as prolotherapy and ligaments, it's usually 10 to 15%. Casey, and how do you get leukocyte poor PRP from centrifugation? Pretty easy. You have to do a double spin technique. I certainly can get into the weeds of describing how that's done, but I don't think that's all that important for a patient level audience, other than to understand that at the end of the day, you can get leukocyte rich, which tends to be red, or leukocyte poor, which tends to be amber. Those are two different kinds of PRP. I think I've had this problem before pronouncing your name. I apologize. Alias, maybe. I've had two posterior PRP, C0 to C7, all ligaments and tendons and muscles. Feel a lot better, instability is back, a lot of symptoms almost gone. However, I still hear a little bit of cracking when turning the neck. I'm 3 months out from my second round. Why could this be? Yeah, Elias, again, just realize that there's 8 different kinds of CCI. That's my subtyping system that we're about to publish on. And In that subtyping system, one type of CCI, 3A, works great with posterior injections. But if you had, let's say, a type 2B, that's not going to change from posterior injections, or it's very unlikely to. So the first question I would ask with a patient with this kind of history would be, does this patient have a kind of CCI that is not responsive to posterior injections? So maybe you had two types, right? 3A plus 2B. The 3A is doing well because of the posterior injections, because it's responsive to posterior injections. The 2B isn't, because it's really not responsive to posterior injections. So those are the kind of things I would be thinking about. Papaya, 2021-22 PICLs. I'm thankful for every single day, but you both care about this unfortunate condition. Amazing humility and humanity you both exude. Thank you. I should have gotten that one on when I had Dr. Schultz. Thank you for those kind comments here. Waya, what do you think about using fibroblasts to help mitigate HTP or significant disc bulges? Is there a positive efficacy utilizing this at all? Thank you both. Fibroblasts aren't available to be used at this point. You could certainly isolate fibroblasts in a lab using a digestion technique. You could certainly culture fibroblasts, but that would produce a drug substance here in the United States, and that would need to require full FDA approval. So they could be great for that purpose, but we're not going to know anytime soon, because that produces a prescription drug that requires full FDA approval, which is about 10 years and costs somewhere between, well, usually about $500 million in order to get that approval. So we won't know the answer to that one anytime soon. Caleb, curious if binocular vision dysfunction is common with CCI. It is, Caleb. And if you look at the many videos I have on that, so just so that everyone understands here, if you go to my YouTube channel, let me pull it up. So if you go to my YouTube channel here, you can search that channel. And if you were to search vision here on the YouTube channel, lots and lots and lots of videos come up on various visual issues that happen with CCI or any upper cervical spine problem. So a lot going on there. Let's see here. Casey, there's a specific nerve dysfunction involved in MCAS as part of HEDS. You know, it's a good question. I don't think anyone knows for sure the answer to that question. There is this association between MCAS and HEDS. There's lots of theories about why that connection exists. In the CCI population, it could be vagus nerve irritation, since vagus nerve provides input to the spleen and the immune system. But I don't know that anyone for sure knows the answer to that question. Let's see here. I think I answered Julie's question already. Kimberly, does PICL align the dens as normal alignment? Again, if the ligaments are stretched, torn on one side. Yeah, Kimberly, I don't know that the goal is alignment. So I think we're thinking two different things here, right? When it comes to upper cervical chiropractic, the goal is alignment. If you're unstable, by definition, you don't have alignment. So the goal there is to get you stable. How do you get someone stable that's unstable? Is you treat the ligaments, or you just say, screw it and fuse the whole thing. Which is a big surgical procedure. So the goal of a PICL procedure for craniocervical instability is to treat the ligaments and get stability. Now, we may not get perfect stability, but we may be able to help the joints that are getting beat up causing symptoms, or the nerves that are getting beat up causing symptoms, and improve the stability enough so that person isn't symptomatic. A secondary concern then would be the position of everything. And that's why if someone is a good responder to upper cervical chiropractic, we always encourage them to do upper cervical chiropractic with a PICL procedure. If the neck pain subsides when you lie on your stomach, what would that say about that? I probably need to know many more details to answer that one. Zach, do you often see POTS-like tachycardia symptoms improve in patients who have these symptoms when they're treated for CCI? We do, Zach. That's a pretty common one that we see improve when we're treating that CCI patient. So that's a pretty common one. Tracy, can I watch the replay? If so, where? Yeah, Tracy, the replay will be for 30 days on Facebook. So if you're watching on Facebook, you can go back to the Centeno Schultz channel and or the Regenix channel, and it'll be on both those Facebook pages. You can also go to YouTube, which is the YouTube that I'm on right now, and it'll appear under live. So right now, it's happening as we speak on the home page, but after that, it'll live under these live tabs. So realize that those are the places that you can find it. Elving, what do you think is the reason that alcohol works well to avoid flare-ups the day after exertion? Like drinking alcohol when straining your shoulders and neck, I don't get the same effect from muscle relaxant medications. Is it because alcohol is a neurotoxin? You know, Elving, I find alcohol in unstable patients can be a two-edged sword. Some people find that when they drink a lot of alcohol, it tends to make them worse, probably because they're feeling no pain and moving around in ways they shouldn't, and that's causing symptoms. It's less often that I hear that alcohol dramatically helps the symptoms, but realize that alcohol is a numbing agent, if you will. It reduces the speed at which your nerves fire off, and also probably relaxes muscles. So it has a pain effect and a muscle effect. So that could be why it works better than muscle relaxers, because muscle relaxers just reduce muscle tension. There's usually not an analgesic effect as well. Lindsay, does Dr. Schultz focus on any different procedures than Dr. Centeno? We really perform the same procedures in the clinic. My practice has moved more and more towards CCI and PICL over time. Dr. Schultz's practice is also moving in that direction. But I think these days he probably does more other things than I do. I still treat, the knees, shoulders, whatever of my patients, my CCI patients that I'm treating with PICL, and I still have some of my routine patient population that I still see, although that's getting smaller and smaller each year. Dr. Schultz probably sees a bit more of that stuff these days, simply because his practice is maybe a third to a half PICL, whereas mine's like 80%. Lindsay, if I get a nerve hydrodissected, well, I need it hydrodissected again. That all depends on what's wrong with the nerve, Lindsay. So there are certainly times where we hydrodissect a nerve once and it works just fine, and there are times where we've got to do it multiple times. So I don't know enough to answer that specific question. Julie, if these other providers are trying to do PICL, they're calling it something different. Julie, I think one woman in Eastern Europe calls it, that's the gal that showed up at our office under false pretenses. I think she calls it something different. I don't know what the other guy calls it. I think there's a guy in India as well. So 2 in Europe and 1 in India that I know about. So I'm not quite sure what they're calling it. I can only tell you it's not what we're doing at this point in time. So it's a little strange. It's one of the reasons why, we don't really discuss PICL details anymore. We were very free about doing that because, we don't want to be in a situation where someone tries to copy this and kill somebody, or someone tries to copy this and really dramatically disables a patient. We are in the process of identifying clinics that we can teach this to, but we're going to maintain quite a bit of control over that process, i.e., if we don't think that that clinic is safe, they're not going to get to continue, and they understand that from the outset. And that was one of the problems we had with these two folks that showed up at our office. We didn't think either one of them was safe to do this procedure, but they just started doing it and we had no control. So I don't know what the heck they call it, but at the end of the day, it's not what we're actually doing. Casey and Dr. Schultz, where do you see the future of what you and Chris are doing in 10 to 15 years from now? Casey, I think that one got in after Dr. Schultz dropped off, so I'll try to answer that. Well, let's see, 10 to 15 years from now, I won't be practicing medicine, that's for sure. I'll be a really, really old guy, as will Dr. Schultz be a really, really old guy. Where would I like to see this specifically and regenerative medicine go? For this specifically, CCI and PICL, I'd like to have at that point 30, 40 good providers worldwide who are doing this procedure. We've hopefully at that point published lots of different articles on it. We've got our first one coming up here pretty soon. And I'm hoping that the medical community at large understands craniocervical instability better and identifies this sooner. When it comes to regenerative medicine writ large, I think I've made no secret of my career goal, which is to get access to regenerative medicine to more and more people. And I've done that through Regenix, which is a company I founded. We now have 4,000 corporations worldwide that cover all of this stuff, that cover PICL, that cover knee PRP, for example. And those are some big US corporations, medium-sized US corporations. And so my goal there would be getting this stuff covered for the average human that's out there, right? The average person who wants to get a knee PRP injection, who wants to try a PICL procedure before fusion. That's really my career goal, and it has been for quite some time. Now, that's a pretty big career goal, right? That's pushing a huge rock uphill. But we've convinced 4,000 companies to do it, and that means it's not that much harder to convince 8,000 companies to do it. And once we get to enough companies that are offering this, those companies all have United Healthcare, Blue Cross Blue Shield, Cigna, Aetna as their insurers. And we've been going around those big carriers, but eventually those big carriers are going to have to admit that this is what their clients, i.e. the employers, want. So that's really the goal, is to get to that point. Big goal, but I'm still going for it. Brent, if a PICL patient were to switch Dr. Centeno and Dr. Schultz for scheduling purposes, Dr. Schultz perform his own imaging assessment, hands-on exam. Yes, Brent, that's usually what happens, is Dr. Schultz will perform his own assessment, hands-on exam, etc. That could be done either through an additional telemedicine visit and then hands-on exam in the office, or just a transfer with a hands-on exam in the office. Micheline, thank you, Dr. Schultz, Dr. Centeno, for your devotion and pioneering pursuit of excellence for the sake of your patients and your consistent dedication to educating patients. Thank you, Micheline. Yes, both Dr. Schultz and I have that in our DNA. And in fact, I have to say, we talked a little bit about when I first met John Schultz 25 years ago at a surgery center. And one of the things I noted about John was he was different than the other doctors there, right? There was maybe 10 different physicians working in the surgery center doing interventional spine. John stood out because of how good he was with patients, how much he cared about those patients. Whereas the other guys, I would listen to them. You're listening constantly as to what's going on in your background. Even while I'm seeing patients doing my procedures, I'm hearing how the other doctors interact with patients. And I was more generally appalled than not at how poorly they interacted with patients. And John stood out as someone who really cared about those people in those beds. So that's one of the reasons why when Centeno Schultz came up, I approached John. I don't know how to pronounce that. Is there anyone else outside of Centeno Schultz Clinic you plan on training? Yeah, I think I've already mentioned we're working with one Florida clinic now. Now they've got a long way to go. They're going to pursue a stepwise approach. So I think they're coming out in August to get a good handle on C1, C2, and then they'll have to come back to get a good handle on C0, C1. Then they'll have to come back again to get a good handle on PICL. But that is in process as we speak. I think their first visit out is in August, if I'm correct. McLean, this condition might more commonly recognize. Yes, I would agree, McLean. That is the goal. Julia, thank you. Lori, stem cell work for my daughter, and she wants more for greater stability. Great to hear, Lori. Kind of random question. If someone works remotely and can move to Colorado during PICL treatment, would there be an advantage? Yeah, that's an interesting question. It's probably not bad, right? I mean, Colorado is a great place to be. I always tell patients, it could be worse. It could be Detroit or something. I mean, obviously, it's a beautiful place to be. So there's a lot of reasons to come to Colorado. It's a major place where people go. And would it be, I tell you, it wouldn't be bad to be local, right? If patients are local, they can do things like pop into the office at 3 weeks after just to check on something, or we can send them to our preferred local providers that we work with that we know really, really well and really, really trust because we have years and years of experience working with them. So I have to say that that's not a bad idea. Obviously, remote work opens up that possibility, but it's not one we've gotten a chance yet to really dig into. We have seen patients who have moved here for short periods of time, and that's generally helpful. But if you could just change your work site and live in Colorado while you're getting treated, I do think there are some advantages to that. Ronald, someday I hope stem cell treatments will pay for Medicare and Medicaid. Yeah, Ron, I would agree with you. That would be the goal, right? We started with 4,000 companies that we have now. Let's say we go to 10,000 companies, then maybe we have United Healthcare and Blue Cross Blue Shield that allow these treatments to happen and get paid for. And then from there, it's not a big stretch to Medicare and Medicaid, but you have to push that rock up those three hills. The first one is, can you get self-insureds to cover it? The second one is, can you get the big 3 or 4 insurers to cover it? And then the final one is, can you get the government programs to cover it? Can moderate laxity of the nuchal and capsular ligaments in HEDS cause overloading of the alar ligaments? Not that the capsular ligaments don't do a lot as far as providing stability. The nuchal ligament does quite a bit. And so if you had laxity in the nuchal ligament, that might cause overloading of other ligaments like the deep ligaments in the alar. Mercia, do you think alar ligament laxity can be restored if kyphosis is not treated or healing will be limited? I think that it's always better to try to restore normal posture if that's possible. Now, there are times it's not, right? Some patients don't really understand what's going on with them as they get more and more and more of this because they're looking at screens all day. Some people are genetically predisposed to kyphosis like that. And so there's certainly situations where we can't restore the normal posture because the shape of the vertebra have changed. So the answer is probably not ideal. Having said that, we do have patients who can't change that, who seem to do fine. Maybe they're at higher risk for more problems down the road. That will remain to be seen. But it's a great example for all of us to constantly work against gravity and stop doing this all day, because this in general is going to make lots of things worse, including whatever's going on in your upper cervical spine. Zach, aside from focal defects, have you seen any MRI evidence of cartilage regrowth from any treatment with PRP, BMC, stem cells? Zach, the biggest thing I think we see, and now that we know across multiple different studies, some of which we published, some of which others have published, is that we tend to see fewer bone marrow lesions in patients who have widespread osteoarthritis, like in a knee, with these type of regenerative treatments, in particular bone marrow concentrate intraosseous and or PRP. And so I think those are the structural changes we see. Now, can you take someone who has a small amount of arthritis and make it structurally better? That seems to be possible based on the existing research. There's also some good research that would suggest that PRP reduces osteoarthritis progression. And again, we have the research that shows that structurally we see fewer bone marrow lesions. Having said that, can you take someone who has severe knee osteoarthritis and no cartilage and regrow them a new knee? You cannot, and that's unlikely to ever occur based on how that happens. So I think our future strategies will really focus on using biologic treatments early to try to prevent getting to that very severe osteoarthritic knee. Any CCI patients you have seen with unusual symptom presentation, for example, heavy head feeling without other symptoms. We see them all the time. We call them atypical. And so we see a good number of atypical patients out there. But as to whether or not we have someone who just has a heavy head and only a heavy head, that one I'd have to think about. I don't know the answer to that one off the top of my head. Caleb, Lori Callahan, does she have dysautonomia? Did it help with that? I don't know who Lori is. So Caleb, I'm at a disadvantage there. And we try not to talk about specific patients here for lots of reasons, including HIPAA, patient privacy, et cetera. Have you seen a patient's overhang improve somewhat from just posterior injections? Perhaps the C1C capsule was torn and caused PRP to leak out. Not really. I think if you're seeing decrease in C1C2 overhang with posterior injections, you're either doing a heck of a lot of posterior injections, 8 to 12, and the effect that you're getting is probably because you are decreasing the patient's overall range of motion by hitting the posterior injections that hard, or you put them in a collar on top of your posterior injections. I've seen that happen a lot, where we have these clinics that do 8 to 12 posterior injections, then they'll put someone in a collar. And when you do their follow-up DMX, their C1C2 overhang looks a little better, but the fact is they've lost a lot of range of motion. So functionally, you didn't really change much. You kind of reduced one problem, but caused another that's going to give them problems down the road. Cassian, are bulging discs always pathologic or some just consequent of general instability? Yeah, bulging discs are not always pathologic. They're just part of the normal aging process. And that's an important thing for patients to realize. A lot of what's on an MRI, a DMX report, is just normal wear and tear. And that happens to all of us as we age, or most of us as we age. The art in medicine is trying to figure out, of those imaging findings, which ones are actually associated with symptoms and which ones are important. I don't know what that means. Maybe HEDS. I'm not quite sure. Edgar, is it common for CCI2B to cause upper extremity weakness, thoracic pain symptoms? Edgar, we have seen that. The first thing you'd want to look for upper extremity weakness would be problems in the lower cervical spine, C5-6, well, really C4-5, C5-6, C6-7, C7-T1, disc bulges. If there's nothing else out there that could be causing those symptoms, we have seen them come from CCI type 2B. But really the first thing is trying to make sure that those symptoms aren't coming from something else. Elliot, what would explain variation in symptoms day-to-day with CCI, different structures getting hit from different movements? Yeah, Elliot, it's usually because it's very activity-based. It's also based on how you slept last night. When you have something that's unstable, that's pretty common. And it gets worse when it's the spine, right? So for example, in some of our CCI patients, just sleeping a certain way can cause the next day to be really bad, because while they were sleeping, things got so much out of place because they're unstable that certain nerves were affected, for example, or a joint got inflamed. Or same thing happens from a day-to-day standpoint. They're going about their lives and they do something a little different that day, or they're a little bit more active because they feel better and they pay for it the next day. So usually that explains what's going on there. But yes, it could be irritation of one nerve one day and another nerve the other day, or one joint one day and another joint the next day. Have you seen HEDS DMXs without overhang? Is almost universal amongst HEDS. I would say it's more likely that HEDS patients have overhang, which makes it more critical for us as physicians trying to make sure that that overhang is leading to their symptoms. And that's one of the reasons why we're so careful about trying to make sure that all of these parts and pieces fit together, right? That the symptoms match the clinical exam, match the imaging. What makes CCI generally better makes the patient better. What makes CCI generally worse makes the patient worse. And we try to get all those things to line up before we'll agree to treat the patient. Or if they don't all line up, to make sure the patients understand that they all don't line up, and our confidence that the CCI is causing the symptoms is less. Snowmass, if more stability and support are provided at C1, C2, would disc bulging at C5, 6 improve? Probably not. Andrea, could a PICL help an overhang of 8, something in 3.5? I also have chronic Lyme and co-infections and mold, and some heart bloating in my neck. Andrew, yeah, I would say that we routinely see, I put overhangs into a couple categories. There's the less than 3 to 4, which is generally normal. So 3.5 is kind of in there. It's on the cusp of being normal, abnormal. Then you get into the, let's say, 4 to 6 range, and then the 6 to 8 range. And then, there's a few out there that are 8 plus, but those are normally patients with specific anatomy that they're born with. So when it comes to the 6 to 8s, we do see 6 to 8s, and they seem to do just fine. Thank you so much, TT. Snowmass, if shoulders are pulling down on the neck, how can this be treated, or can it? It can be. So you would either, you have to find out what's causing the tightness. I think what you're describing maybe is in the upper traps, levator, scalenes, and then you've got to fix that or try to treat that thing. So that's really the big challenge there, is what's causing that. Snowmass and overhangs reduce from posterior treatments providing outer stability. Generally not. We generally don't see decreased overhangs, as I was talking about before there. And if you do, it's because usually that you've just sort of traded one problem for the other. Meaning you've made the person lose range of motion because you've banged on the neck so much with a dozen treatments, for example, or you put them in a collar. And so you solved one problem, but you caused another. So not a real great way to treat an overhang with posterior injections. Sure, happy to help. As many know, my goal is trying hard to answer as many questions as I can. I've got this venue to answer questions. I do videos to answer questions. We've got the PICL Reddit thread, RPICL, where I answer questions. And it's simply because, there's lots of people out there and lots of misinformation. And my goal is just to try to provide good information. I don't care if I ever see you or not as a patient. But if I can reduce the suffering or reduce the anxiety in the patients that have this issue, that's a win. Cassian, what size and type research needs to be done to get insurance coverage PICL? Okay, so it's going to be a long time before insurance covers this, meaning the big three, but I talked about the process there, right? The process we have so far, for example, where we have 4,000 companies that cover a PICL. You got to get to 10,000 or 20,000 companies. Then you start getting enough impetus behind this that you can get one of the big 3 or 4 insurance carriers to cover it. As far as the type of research that has to be done, that's normally randomized controlled trials. But even then, doesn't make a difference. We have 150 randomized controlled trials, for instance, for PRP use in various areas. For the knee alone, there's 3 dozen. For the lateral epicondyle, there's 2 dozen randomized controlled trials. So really, it's some of that, but it's a lot of getting self-insureds to cover this so that the large carriers don't have any other choice. If they've got, if you've got 20,000 companies across the US that cover this, but Blue Cross Blue Shield doesn't yet cover it, but Blue Cross Blue Shield has 7,000 of those companies, now you're getting into a situation where Blue Cross Blue Shield has to kind of cover it because they have 7,000 of their customers who are doing this, and they're going to start to hear it from those other customers if they don't cover it. So that's generally how this stuff works. And that's the path we've been pursuing now for a decade or more. Austin, is it recommended 2 to 4 PICLs? Is it possible to go ahead and schedule those with you since the wait is getting longer and longer? Yeah, Austin, we generally don't do it that way. We do one. Well, first you got to get all the imaging, then we do a telemed. If you're deemed a candidate, you can get on the schedule for the first one. That's with myself, Dr. Schultz, or Dr. Pitts. Dr. Schultz and Dr. Pitts have less of a wait time than I do, largely because of the way I do my schedule, but also the demand. And then once we do that first one, we reevaluate to make sure we're on the right track. We do not, like many of the prolotherapy clinics out there, just schedule you for 6 or 8 of these and call it good. We don't do it that way because we want to make sure we're headed in the right direction. Solis, is all doctors and Regenexx provide? No, Solis. The only place you can get any CCI care in Regenexx right now is in Colorado. That's the only place that you can get that. JS, did you say you take United Health Care, Medicare? No, we do not. Well, that's not true. As a clinic, Centeno Schultz is on United Health. Centeno Schultz does not take Medicare at all. We do take pretty much all of the private insurance companies that are out there, United Healthcare, Aetna, Cigna, Blue Cross Blue Shield, etc. As far as getting coverage for regenerative medicine, that's not available through the big insurers, but that coverage is available through Regenexx at around 4,000 different private companies. So these are people that work, for example, for Company X, and Company X has chosen to cover this stuff. So I think I got that one already. Greg Jubert, hello, currently in process of working with you guys. How do you choose which doctor the patients work with? It's case-by-case basis. Yeah, I think it's more of a case-by-case basis. The goal here is to try to get the patient seen in a timely manner. So you might get on my schedule, you might get on Schultz's schedule, you might get on Pitts' schedule. Do adhesion occur in any of your procedures? Not quite sure what you mean as far as any of our procedures, so I need a lot more than that. But in general, adhesions would not be the goal of any of these procedures. Alec, how difficult to tell if patient's symptoms are being caused by basal invagination or AAI? Are imaging symptoms enough to make that determination? Have you seen PICL procedure produce results in patients who have both? Alec, the first thing to note is about 90% of the patients who believe they have basal invagination don't have it. So that's the first thing we have to get through, is looking at your images and trying to see if you actually have basilar invagination. Again, 9 times out of 10, a patient thinks they do, but they don't. Atlantoaxial instability is a common cause. That's that type 2B or type 2A CCI. So all of that is made off of reviewing your images and then doing a hands-on exam and putting all that together to try to see which one is more likely to cause symptoms. Again, most people who think they have vasovagination do not. Haley, hello, doctor. There's quite a few nerves treated with you, PICL. Thank you very much. We treat the nerves like the occipital or superior cervical plexus, for example. You're always hydrodissecting. What is the difference between hydrodissection and other approaches nerve treatment that you may have? All hydrodissection means, Haley, is that we are using ultrasound to place, in our case, platelet growth factors to help the nerve around the nerve. So it's nothing more than that. So if you had those nerves treated, then that's what that means. There really isn't a whole host of different ways to treat a nerve. That's usually the way a nerve is treated, through injection. JS, what kind of symptoms occur when disc is pushing this to the spinobule and causing, I'm not sure what that word means, causing narrowing of the canal. So if a disc is pushing into the spinal canal, and that is irritating the spinal cord, there are lots of different ways to treat that. Now, in some patients, you need surgery to remove the disc. For most patients, you don't need that. But I need to know a lot more. But I will leave you with this, right? I've got multiple disc bulges and a small spinal canal because I was born with a big head. And at the end of the day, if you would ask me 7 or 8 years ago, when all of that really flared up for the first time and I got my first cervical MRI, while I was sitting in bed that day, I would have said, I'm going to end up getting a surgery. Never got the surgery, used regenerative medicine. Here I am 7, 8 years later, fully functional human who's never had surgery. So I'm a walking testimony to this approach. Shannon, what do you need to do? What do I need to do with C7, C3 fusions, bone grafts, rods, 16 screws? Can't afford prolotherapy. I know I have CCI vagus nerve damage. Shannon, I don't know how to answer that question. It sounds like you've got multiple different fusions in your neck. So I don't know. I would have to, again, the process would be you'd have to see one of our doctors, get a telemedicine evaluation, see what your next best steps are. If you need additional surgery, for example, if the hardware needs to be removed, there's lots of different decision points in there. Doc Smith, Jing Palace, I don't know what that means. Dr. Centeno, are you familiar with loading the head to erect spine, engage posterior and release anterior method to transform the condition? I think what you're referring to is the idea that if you restore posture and load the head, that you can help patients. And I would say that as long as that's in that safe conservative care vertical, it's a reasonable thing to try. Just realize that by definition, most of my craniocervical instability patients would get much worse with that approach because of their craniocervical instability. So I don't know that's a valid way to treat this patient population, or at least most of the patients we see. And guys, I'm trying to work through the questions just because I got a little behind there interviewing Dr. Schultz, but I have 2 more here. Does PICL help a lot of severe neurologic symptoms, AI and CCI cause? I mentioned I have 8.5, 3.5, very severe. It can, Andrea, but again, you would have to get a telemedicine evaluation. We'd have to look at everything in context. Yeah, Dr. Smith, Jing's Palace. I don't know if I'm going to answer that one. Okay, guys, I think we are coming to the end here. I've been on about an hour and 10 minutes or so. I did want to have everyone hear from Dr. Schultz because he's been there since the very first PICL cases. He's done about 400 or 500 of these PICL procedures, and we work very, very closely together on all of these cases. And so I wanted people to meet him because he hasn't been on here with me before, and see what a great guy he is and what an excellent doctor he is. And we'll end with this one. Thank you, JS, for that shout out. So again, thank you so much for spending time on this Sunday morning. We've got the RPICL Reddit thread where you can join and get questions answered pretty much 24/7, 365. And then the YouTube channel is out there. Please join that, subscribe, etc. And just have a great week. Thank you, Julie. And I'll be back next weekend with another topic, maybe another interview. We'll have to see how that goes. I know I want to get Dr. Pitts on here at some point, so maybe we'll do that so you can meet him. Thanks so much for watching, everybody. Have a great week, and I'll see you next week.